Ophthalmology of Society of Ophthalmic Surgeons case discussions for the postgraduates. And as you know, these sessions are incredibly vital for our shared learning. And I would like to extend special thanks to Dr. Bastin, our scientific committee chairman, for orchestrating such a valuable program and for giving me this opportunity to address you all. We are especially honored today to have two esteemed educators with us, Dr. Suresh A., Professor of Ophthalmology at JJMC Davangere, and Dr. Soumya Nambiar, Senior Consultant at Comtest Hospital, Kozhikode. A very warm welcome to both of you. A special thanks also to Dr. Rohima, who is presenting today, and to each one of you participants. Your engagement is what truly enriches these sessions. Now, without further ado, I would like to invite Dr. Soumya Nambiar to please carry forward this program. Thank you.
Thank you, Dr. Rajesh, for giving me this opportunity. And I would also like to thank KSOS and especially Dr. Bastin, sir, for having given me this opportunity. Um, PG update module 18. This is what we are going to deal with today. And definitely, it's a very good platform by the KSOS, and it's a very good initiative by the KSOS for having started this PG modules. And you all have all the PGs who are joined here and who are joining us on YouTube. It's a platform where you can do mistakes and learn from your mistakes. And here we have Dr. Suresh, who has almost 15 years of experience in conducting UG examination, as well as almost eight years of experience in conducting a PG examination. So you will get a good idea as to how the exams are going to be conducted in your future practical exams. So I would request each one of you to take this opportunity and present and take all the advantage of this platform. So we have here Dr. Rohima. She is a junior resident from Comtest Hospital. So I would request all others to mute yourselves, and whenever you can be intervened at any time of your presentation, Dr. Rohima, and also the other PGs, we can ask questions to any one of you all, and feel free to answer them and also to make mistakes and learn from your mistakes. Okay, Dr. Rohima, if you can share your PPT.
Okay. Madam, is my screen visible, madam?
Not yet, Rohima. Only Zoom, this thing is coming.
Okay.
Yeah, now it's visible. Can you make it go to the full screen now option?
Yes, madam.
Yeah. Okay. Suresh sir, can we start now?
Yeah, sure.
Yes, sir. Thank you.
Good evening. Today, I am presenting the case of Mrs. Daisy Jose, a 53-year-old lady from Manandavadi, from Wayanad, and she is a homemaker. And she is presented with complaints of headache for 10 days duration and drooping of right eyelid for 7 days duration. Coming to the history of present illness, she was apparently normal 10 days ago when she noticed right-sided headache, which was dull aching in nature and lasted for about 3 days, and it is relieved by analgesics. She gives no history of any associated fever, vomiting, nausea, neck pain, and 3 days later she noticed dropping of right eyelid, and she went to the nearby hospital, and she was given some lubricant eye drops and topical NSAIDs and was asked to review after 2 days. As the symptoms were persisting, she came to Comtest High Hospital for a second opinion. There is no history of double vision, diurnal variation of dropping of eyelid, no history of trauma, no history of generalized weakness, tingling sensation. There is no history of seizure. and there is no history of difficulty in swallowing and no history of similar complaint in the past. Coming to past medical history, she is a known case of diabetes mellitus on oral hypoglycemic.
Can I intervene, Rohima?
Sure, sir.
Can you please go back to your previous slide? Okay, what is the age of the patient? I forgot.
53-year-old. 53-year-old, sir.
53-year-old.
Yes, sir.
Okay. Headache and drooping of the eyelid is a main complaint. Okay. What are the possibilities you are keeping in mind with these complaints?
Since the patient is an old age patient and she's diabetic, we can think of in vascular conditions like ischemia and all. Then, since the patient is having headache, we can think of migraine, and patient is also having drooping of eyelid. We can think of in the view of
Can you put the next slide, please? Next slide. Okay, what happened to the pain? It totally got relieved after the initial attack.
After taking analgesics, the pain relieved, sir.
So she had only pain for 3 days. Afterwards, she developed ptosis.
Yes,
She
sir.
noticed ptosis, after which these all symptoms of headache got relieved.
Yes, sir.
Is that correct?
Yes, sir. She had headache 3 days
Okay.
before the appearance of ptosis, sir.
Okay. Okay, can you just tell me why you have asked all this negative history?
Um, uh, for the history of fever and vomiting, I aimed at infective conditions like meningitis, any other infective conditions. And for nausea, neck pain, meningitis were ruled out. Then for the negative history of diurnal variation, I think of myasthenia gravis. Then trauma can be a cause for ptosis. Then generalized weakness, that indicates any stroke. Then tingling sensation for any
How was the
demyelinating.
ptosis which has remained same?
Sorry, sir.
Ptosis remained same.
Ptosis was remaining.
Ptosis, drooping of the eyelid remained same. Is
Yes,
neither
sir.
progress nor no this one alteration.
Drooping of eyelid is she's having symptoms for 1 week.
Okay.
It is not. It is same, sir. It is not improved during the past 1 week.
Okay. 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 Right. Please continue.
Past medical history, she is a known case of diabetes mellitus on oral hypoglycemic agents and insulin, 20 units in the morning and 15 units in the night. And last random blood sugar value was 207 milligram per deciliter 1 week back. And HbA1c was found to be 10.7. And she's a known case of hypothyroidism and on thyroxine for 5 years, for the past 5 years. And there is no history of any coronary artery disease, dyslipidemia. Coming to past ocular history, she is using prescribed reading glasses for the past 4 years for reading, and last spectacle change was 1 year back, and there is no history of any ocular surgeries in the past. Coming to family history, there is no significant family history. Personal history, she consumes mixed diet. Her sleep and appetite is normal. Bowel and bladder habits are normal. There is no addictions to alcohol, smoking, or caffeine. Then,
Why you have asked history of migraine headache in this?
since the patient is having one-sided, right-sided headache, I asked history of migraine.
Okay. Can that cause ptosis? Migraine?
Ophthalmoplegic migraine can cause ptosis.
Okay, usually how do they present and how they progress?
Patient may present with severe headache along with ptosis, and patient may also have symptoms like nausea, vomiting, photophobia, phonophobia, and all.
Usually seen in children, migraine headache, and it will not persist for so long time. They will
Yes.
recover.
Okay, sir.
Okay.
Coming to general examination, patient is moderately built and nourished. She is conscious, cooperative, well oriented to time, place, and person. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, pedal edema. Skin, hair, nail are normal. There is no palpable thyroid gland swelling. Coming to the vitals, pulse rate was 70 per minute, regular in rhythm, normal volume and character. Blood pressure 140 over 90 millimeters of mercury in the left upper arm in sitting position. Respiratory rates were 16 cycles per minute. Systemic examination, respiratory system, normal vesicular bed sounds are heard bilaterally all over the lung fields. Cardiac system, S1, S2 heard normal, no murmur. Gastrointestinal system, per abdomen soft and tender, there is no organomegaly. And central nervous system, in central nervous system, higher mental functions were normal. Cranial examination, second, third, fourth, and sixth are evaluated along with the ocular examination. So coming to the cranial nerve 1, there is no anosmia and or parosmia. Cranial nerve 5, the motor components which include temporalis, masseter, and pterygoid muscle was normal in both, normal bilaterally. Sensory ophthalmic, maxillary, and mandibular divisions of the sensory divisions were normal bilaterally. Conjunctival and corneal reflexes were normal bilaterally. Coming to cranial nerve 7, wrinkling of forehead was normal in bilaterally, blink rate was normal, Bell's phenomenon was good bilaterally, and forced eye closure was normal. Nasolabial was also normal bilaterally. No deviation of angle of mouth seen bilaterally.
Anything of these other than ocular importance, any other cranial nerves involved?
Along with this third cranial nerve,
All are
other
other than all are normal, no?
yes, sir.
All other cranial nerves. Maybe you can skip that then.
Okay. All other cranial nerves were normal. Now, coming to the examination of motor system, tone normal in the upper limb and lower limb. Bulk, power, and reflexes were also normal. Coming to the sensory system was normal. No cerebellar signs seen, and there is no signs of meningeal irritation. Coming to the ocular examination, with torch-like examination, head posture was normal. No facial asymmetry is noted except for the right side ptosis, and right eye complete ptosis noted. And Hirschberg test is done after passively elevating the ptotic eye, and the findings was 15-degree exotropia. Since the patient is having right eye complete ptosis, I will discuss the ptosis workup part. The palpable fissure height was 0 in the right eye and 11
What's the
millimeters.
ocular posture?
Head posture
Can you
was
mention
normal.
about ocular posture?
Head posture was normal, sir.
Ocular posture. Hirschberg test. What is the position of the eyeball?
The eyeball
After
is rotated down and out. After elevating the ptotic eyelid, I could see that the eyeball was rotated down and out, sir.
okay.
Ptosis workup, palpable fissure height was 0 in right eye and 11 millimeters in the left eye. MRD, marginal reflex distance 1, minus 6 millimeters in right eye and 5 millimeters in the left eye. Marginal reflex distance 2, 6 millimeters in both eye. Marginal crease distance 8 millimeters in both eye. Levator function test was 7 millimeters in the right eye and 15 millimeters in the left eye. ISPAC test, hearing fatigability, Bell's was negative bilaterally. Bell's phenomenon was good. Cogan-Titch was negative in both eyes. Coming to the extraocular movements, first I will discuss ductions. For the right eye, there is a limitation of grade -3 noted in the elevation, depression, and adduction. And in the left eye, ductions were normal. Then coming to versions, binocular movement versions in the right eye, there is a limitation of grade -3 is seen in all the gaze except the abduction of the right eye. Intorsions were normal bilaterally.
How did you assess the intorsion?
Intorsion usually we assessed by marking a conjunctival vessels, and we'll ask the patient to look down, and if there is if the intorsion is present, we can see the movement of the vessel, conjunctival or limbal vessels. The primary superior rectus is the muscle which is involved in intorsion.
What for you tested for this intorsion?
Sorry, sir.
To assess the superior rectus function? No. Why did you test the intorsion?
To know other cranial nerve involvement. If there is any involvement of the fourth cranial nerve, intorsion may be affected.
Okay. You assess for fourth nerve, right?
Yes, sir.
So if it is a very minimal movement, how do you appreciate that?
If it is a minimal movement, we can appreciate via slit lamp, sir.
Yeah, you should mark the vessel and examine the slit lamp. Correct.
Coming to the 9 gaze positions, the primary position, in the primary position, the right eye was down and out. In dextroversion, the movements is full and there is no limitation. In dextro elevation, there is a limitation of grade -3 noted in the right eye, and in dextro depression, there is a limitation of grade -3, and in levo version, there is a limitation of grade -3 in the right eye, and in levo elevation also there is in levo elevations and also in levo depression, limitation of grade -3 is seen, and elevation and depressions are also limited. So coming to vergence, convergent limitation is present, divergence is normal. Saccades, floating saccades are noted in right eye. So coming to the sensory examination, binocular single vision, diplopia was present at near and distance, which is assessed in Worth 4-dot test. Next, coming to the motor examination, cover
What
test.
type of diplopia was there?
Sorry, sir.
Can you hear me?
Sorry, sir. Pardon.
What type of diplopia? How did you assess the diplopia?
Patient had paralytic lip skin, sir. Since the patient is having exotropia, patient will have crossed diplopia, sir.
Okay, what do you mean by cross diplopia?
In cross diplopia, the two red dots are seen in the inner part, in the left side of the chart. Worth 4-dot test, sir.
You use how do you do diplopia this one assessment using this one?
Diplopia chart.
How do you assess the diplopia assessment?
Diplopia assessment is done with four daughters. After correcting the head posture, we'll give the patient a red green goggles, and we'll ask the patient to wear. Patient is wear the glass in such a way that the red goggle in front of the right eye and green goggle in front of the left eye, and we'll ask the patient how he or she sees, and we'll yes.
No, if you want to assess the diplopia in all the gauges, do you use Worthford dot test for that? At 6 meters, you're telling?
I can also go for diplopia chartings.
How do you do diplopia charting?
Diplopia charting.
If you want to do diplopia charting in all the gauges,
Okay.
use what is a better way of doing it? This you did with 6 meters?
Diplopia charting is done at 1 meter distance.
You have done this diplopia for that only, or what?
For 1 meter distance, I have done, sir.
Using Worthford dot test used for that?
For in Worthford dot test, we are testing BSV.
BSV are doing, not diplopia charting.
Okay, sir.
No, here you did it for BSV or diplopia charting that.
BSV, Worthford dot test was done for checking BSV. Then diplopia charting is also done, sir.
BSV have done. In that only.
Yes, sir.
Using that Worthford dot.
Yes, sir.
Why you want to use that simple any slit with red green glass patient sitting at 1 meter is enough, no? Why you want to use that? In different all gauges you can assess.
In the primary case only we can assess BSV using Worthford test.
BSV is fine. I am asking for diplopia charting.
Diplopia charting is done in all the 9 gaze positions, sir.
For that you use this Worthford dot test?
No, sir.
Okay, that's what I want.
Sir is asking, what did you use to do the diplopia charting? For 9 days you checked, no? What did you do? Is what he's asking.
Patient is asked to wear a red green glass, and a horizontal slit is shown to the patient, and will ask the patient how she sees, and then we'll mark.
Okay.
You
Right.
use horizontal slit or vertical slit?
Vertical slits are used, madam.
Okay, what are the things you observe while doing that?
How much is separated? If there is any horizontal, we'll check for both horizontal and vertical deviation, and we'll check in which position maximum separation is there. Then we'll check whether it is crossed or uncrossed.
Okay. Any tilting of?
Yes. Okay. We can also check tilting of the images.
Okay. Right. Please continue.
Motor examination. Cover test on covering the left eye. Right eye takes up fixation that suggests right exotropia. Uncover test on uncovering the left eye. Left eye refixes, and the secondary deviation was found to be more than primary deviation. Alternate cover test. Right eye constant exotropia noted. Prism bar cover test. Secondary deviation is more than primary deviation, which is confirmed with prism bar cover test. This is the diplopia charting of this patient. Here, both cross diplopia is seen with maximum separation of images seen in the levo elevation position.
She has diplopia in all the gauges.
She gives diplopia in all cases, but which was more pronounced in the levo version, sir.
It was right eye, no? Involved eye.
Yes, sir. Right eye is involved.
So can you expect any no any gauges without diplopia in this? Is that possible to have without diplopia in any case?
In abduction, in dextroversion, patient might not have diplopia, sir. Since the abduction is normal, in dextroversion,
Yeah, in the extroversion,
patient may not have diplopia. We can expect that, sir.
but in your stall position, they're having diplopia. That's why
Oh.
I'm asking.
Yes, sir. In patients said like that, sir. That's
They can have vernacular single invasion in one gaze, no?
yes, sir. In dextroversion, patient can have.
But here, all the gauges have diplopia. That's why I asked. Okay. They can have, no? At one small area, they can have single vision in dextroversion.
Yes, sir.
Right. So you should also mention patient's right and patient left. In diplopia chart, it is not universal. Sometimes right and left is not universal, this one. So whether what's patient right and patient left also should mention. It can be reversible.
Yes, sir.
In that chart, that R and L you have written, no?
Yes, sir.
That there better to mention patient's right, patient left.
Yes, sir.
So other way also is possible.
Oh, yes, sir. Coming to the assessment of vision, unaided vision was 618 in the right eye with no pinhole improvement. And left eye, the vision was unaided vision was 618 parts with improving to 69 with pinhole. Near vision was N12 with an addition of plus 2.75 diopters in the right eye, and near vision was N6 with an addition of 2 plus 2.75 diopters. Visual field by confrontation was normal, and color vision was normal bilaterally. Retinoscopy is done.
Anything specifically you look for in the near in this refractive error in this third no policy? Do you want to anything specifically look for?
In third nerve palsy, the near vision may be affected because of the deficient accommodation. If the accommodation is affected, near vision may be.
Okay. Right.
A retinoscopy is done at 66 centimeters with tropicamide and phenylephrine, and I got a value of plus in the right eye. I got a value of plus 3.25 in the vertical and plus 3 diopters in the horizontal meridian, and in the left eye plus 3 diopters in the vertical and plus 2.75 diopters in the horizontal meridian. Coming to the examination, slit lamp examination, right eye, eyelid and adnexa, ptosis was present, which is described earlier. Then in left eye, eyelid and adnexa was normal. Conjunctiva was normal bilaterally. Cornea normal in size, shape, transparency, and corneal
Better
sensation.
you should finish one eye and go to other eye. If you mix up both eye,
Oh, okay, sir. Sorry.
I think that is a usual practice, everywhere practiced.
Oh, yes, sir.
So finish examination of the one eye complete, then go to other eye.
Oh, sure, sir.
You mix up
Examination. Okay, sir. Examination of right eye, eyelid and adnexa, ptosis was present. Conjunctiva, normal in the right eye, and cornea normal in size, shape, transparency, and corneal sensations were normal. Anterior chamber Von Herrick grade 3, there is no cells or flare. Iris normal color and pattern, no neovascularization of the iris is noted, there is no iris atrophy. Lens was clear. Pupil was 3 millimeters, round and central, and direct and concentric reflux was present. And intraocular pressure with Goldman applanation tonometry, which is done at 4 p.m. on 12th June 2026, was found to be 80 millimeters of mercury. And gonio was open, and there is no neovascularization of the angle in the right eye. Then coming to the examination of the left eye, eyelids and adnexa was normal. Conjunctiva normal, cornea normal size, shape, and transparency. Corneal sensations are normal. Anterior chamber Van Herrick grade 3, no cells or flare. Iris normal color and pattern. No neovascularization of the iris is noted. Lens, no iris atrophy. Lens was clear. Pupil was 3 millimeter, which was round, central, and direct and consensual reflux was present. There is no RAPD. Intraocular pressure with Goldman applanation tonometry at 4 p.m. was 16 millimeters of mercury, and gonio was gonio, the angle was open, and there is no neovascularization of the angle. Coming to the fundus examination of right eye. Media was clear, disc was vertically oval, normal in size, pink in color, with well-defined margins with a cup disc ratio of 0.3 and an arteriovenous ratio of 2.3. Vessels arising from the center of the disc, branching dichotomously, and foveal reflux was dull. Background retina shows a few pin-shaped hemorrhages and other dot and blot hemorrhages in all the 4 quadrants, suggestive of severe non-proliferative retinopathy changes, and peripheries were within normal limit. Coming to the fundus examination of the
Only hemorrhages are seen?
Sorry, sir?
In all 4 quadrant, you observed only hemorrhages, no other changes other than hemorrhages.
Only hemorrhages was there, sir. There is no hard X-rays and rules.
Okay, no other things. Only hemorrhages in all 4 quadrant, right?
Yes, sir. Pin-shaped hemorrhages and dot and blot-shaped hemorrhages were seen, sir.
Okay.
Fundus examination of the left eye. Media was clear, disc was vertically oval, normal in size, pink in color, with well-defined margin, with a cup disc ratio of 0.3 and AV ratio of 2.3. Vessels arising from the center of the disc, branching dichotomously. Foveal reflexes was dull. Background retina shows few pin-shaped hemorrhages and dot and blot hemorrhages in all the 4 quadrants, suggestive of severe non-proliferative diabetic retinopathy changes, and peripheries were within normal limits.
Why do you say it is severe NPDR?
Since the hemorrhages was present in all the 4 quadrants, then AV venous bleeding was there. IRMA, if will define severe NPDR according to the 432 rules.
What is the criteria to say severe NPDR? What is the
If
ETDR's
any-
criteria to say?
If any of the 2 criteria is present among these 3, we can say that this is severe NPDR.
What 2 criteria are there here?
Hemorrhages in all the 4 quadrants, then venous bleeding in 2 or more quadrants.
But you have not mentioned anything venous bleeding or anything here.
Oh, yes.
Are they only hemorrhages or microaneurysms are there? Are there any arterial changes are there?
No, sir. No arterial narrowing noted, sir.
What do you expect the arterial changes in this stage?
arterial narrowing, then vessel wall thickening, sclerosis we can expect. AV crossing changes we can expect, which may causes vascular occlusions. Then
What?
arteriovenous crossing changes, sir.
No. Considering the range, what you expect inner vascular changes?
Narrowing of
Is she also hypertensive?
patient's BP was 140/90 millimeters of mercury. She's not taking any
No,
medication for
only she's
hypertension.
only diabetes. No, she's not an hypertensive patient, right?
Yes, sir.
Okay. Okay. What do you expect to see? Age-related arteriosclerotic changes.
Yes.
50 plus, maybe there or may not be there. But usually age-related arteriolosclerosis changes you can expect in this patient.
Yes, sir. And
But your severe NPDR and findings are not correlating. Only
yes, sir.
hemorrhages you are telling,
Okay,
and
sir.
no other signs to say that diabetic retinopathy. I don't know why you are telling directly this one. No, you are not like mentioning any other diabetic changes. Why they have only hemorrhages without any other changes, I don't know. Maybe patient is also hypertensive.
Patient is not, she's not taking any medication for hypertension, sir. Her BP was, when I examined, her BP was 140/90 millimeters of mercury.
Okay. On all quadrants she has hemorrhages, right?
Yes, sir.
Hmm. Okay. No X-rays or nothing. That's why I asked. And you didn't mention any venous changes except hemorrhages. That is bit not correlating your this one grading and findings.
Sir, can I say it is moderate NPDR?
That's what bit not clear cut picture. I don't know your fundus. Only hemorrhages. Maybe you have to think of hypertensive retinopathy also. Without X-rays, you are not microaneurysms, more of hemorrhages, and no X-rays also. You told, right?
Yes, sir.
Ah, that's what. I'm not sure about your findings. Do you have any fundus picture here of this patient?
No, sir. I didn't have fundus pictures.
You're telling all the four quadrants hemorrhages. With these changes, usually diabetic, if you say severe NPDR, there has to be some other changes, I think. All quadrants hemorrhages. I don't know. Anyway, continue because you don't have fundus picture also. And you cannot say severe NPDR with only that, like as per ATDR's criteria, and no 4-to-1 rule also.
Yes.
So you have to be careful regarding this.
Sure, sir. Summary, 53-year-old 3-year-old diabetic female patient presented with complaints of headache 10 days duration and dropping of right eyelid for 1 week duration. On examination, there was a complete right eye ptosis and a 15-degree exotropy in the right eye, and the secondary deviation was found to be more than primary deviation, and grade 3 limitation of movements noted in the right eye in all the directions of gaze except abduction, and except that abduction was found to be normal. Anterior segment examination was within normal limit, and there is no pupillary involvement, and fundus examination also showed diabetic retinopathy changes.
What is the vision improvement in this patient?
In the right eye, patient vision was 6/8, unaided vision was 6/18, with no improvement. With pinhole vision, it was also 6/18, sir.
Okay, other eye also similar finding.
Uh,
No 18, no
yeah.
improvement, right?
No, sir. In the left eye, her vision was 6/18, which was improving to 6/9 with pinhole, sir.
Okay. Right. What is your diagnosis?
So, so my diagnosis is right-sided, isolated, complete third nerve palsy, pupil sparing, mostly vascular pathology, and with diabetic retinopathy changes and diabetes mellitus and hypothyroidism.
What is the cause for decreased vision in the right eye?
Sometime patient may have macular ischemia, macular edema. Patient may have.
Okay, have you done OCT?
No, sir. The patient didn't come here, sir. We lost a follow-up.
What is your macular findings?
Macular findings, foveal reflex was absent, sir.
Foveal reflex was absent.
Yes, sir.
Okay. What do you want to account for the loss of vision in the right eye? What may be the causes for decreased vision in the right eye?
Maybe maybe due to diabetic retinopathy changes.
Okay. But you have not written any specific diabetic retinopathy changes, very non-specific findings, except all the four quadrants. Is that any venous changes are there?
No obvious venous changes was
No
not.
venous changes, venous dilatation, tortuosity.
No, sir. Tortuosity was not.
Where else you can get such changes? Without this, all four quadrant hemorrhages, what may be the immediate differential diagnosis?
We can think of venous occlusions like
Ah,
CRVO, then
which one?
ocular ischemic syndromes.
Ocular ischemic syndrome and CRVO, right? How do
Yes,
you differentiate between these two conditions?
sir. Usually CRVOs are unilateral. Then
It can be
ocular
unilateral or bilateral.
in ocular ischemic syndrome, we can see asymmetric fundus pictures.
What is the characteristic findings you observe to differentiate between CRVO and ocular ischemic syndrome?
In CRVO, tomato splash appearance is there.
That may, depending on the severity, that has nothing to do with tomato splash appearance.
Yes, sir.
Venous changes. What venous changes we expect between these two?
In CRVO, we can see venous tortuosity, AV crossing changes.
Dilated and tortuous, whereas in ocular ischemic syndrome, they are dilated without tortuosity and they will be only equatorial hemorrhages. Predominantly equatorial hemorrhages, not like uniform all over that. That is venous changes along with so many other changes. That's why I'm thinking because you have no other changes. Is it a case of CRVO?
Yes, sir.
Hmm. That is one possibility with macular edema.
Mhm.
I'm
Yes.
not sure. Maybe you have not done OCT also.
Oh. So then patient didn't come here for follow-up, sir.
Okay. Okay, where do you want to put the ETI or this one? Etiology.
Um,
Where do you want to put the lesion for the third nerve palsy?
History-wise, we can exclude the sites, and in this case, Most probably the site of lesion will be basilar part of the nerve, sir.
Which one?
Basilar.
Basilar portion.
Since the patient is diabetic and aged patient, vascular changes we can expect, sir.
Okay, what is the
Ischemic
cause for palsy in diabetes?
microangiopathy of the vessels that can cause ischemia.
What is the mechanism? What is the cause for pupillary sparing in this case?
In pupillary sparing, because the pupillomotor fibers are located in the supromedial part of the nerve, and in vascular pathologies like diabetic changes and all, usually the vasa nervosum is affected, sparing the pupillomotor fibers.
Mainly it affects the vasa nervosum. Pupillary fibers are in the periphery which are supplied by pile vessels. So
Yes,
which
sir.
are spared, that is the cause.
Yes, sir.
Usually, which is the part affected in diabetic retinopathy?
In diabetic retinopathy, we can see microangiopathic changes.
Intracavernous part, usually.
Yes, usually intra. Yes, sir.
Can it be nuclear lesion?
It cannot be nuclear lesion, sir. Since patient is having only right-sided ptosis and
Okay, what is Daroff's rule?
Daroff's rules are we to identify the nuclear lesions, and there are certain criterias for obligatory nuclear lesions, for possible nuclear lesions, and for non-nuclear lesions.
Okay, which obligate nuclear lesions? When you say it's obligate
If
cardiopathy secondary to nuclear lesion.
if patient is having bilateral ptosis, uh, and we can say it's an oblig. If we can say that it is an
Obligate
open.
cardiopathy.
Yes,
Like
sir.
bilateral ptosis. Bilateral ptosis with unilateral total ophthalmoplegia, sparing superior rectus with contralateral superior rectus involvement. Okay, anyway, you know about Daraf's. Can you list out isolated third nerve palsy causes? All the causes for isolated third nerve palsy.
The causes for isolated third nerve palsies are vascular changes, then
One is microvasculopathy.
then aneurysms in the
Okay.
internal carotid arteries, then traumas, then an intracranial space occupying lesions.
Which one?
Space occupying lesions, tumors, metastasis.
Is those causes isolated third nerve palsy? I am asking you, which are the causes for isolated only third nerve palsy? Isolated third nerve palsy means without involving any other nerves.
Diabetes mellitus, hypertension causing vascular conditions.
One
Then
is microangiopathy, secondary to these vascular changes. Other one is involving aneurysm, which aneurysm causes isolated third nerve palsy.
aneurysm at the junction of internal carotid artery and posterior communicating artery.
Yeah, that's what you told. Carotid artery. Carotid artery aneurysm will not cause isolated third nerve palsy. It will always involve the or cavernous sinus structure. Which other aneurysm can involve the third nerve palsy? Other than carotid artery or posterior communicating artery.
Superior cerebellar artery and posterior cerebral arteries.
Ophthalmic artery. aneurysm can cause. That causes only usually branches. So other causes are oculomotor spasm, migraine, post-migraines, trauma. Sometimes trauma can cause isolated Turner palsy
Yes, sir.
without involving this one. Only thing that time, a trivial trauma presenting with Turner palsy. What do you do then?
Trauma with Turner palsy. Patient is having medial.
Trivial trauma patient presented with Turner palsy. What do you suspect, or you just leave it like that?
If when there is a medial rectus, a medial wall of the orbit is fractured, we can get Turner palsy. Then
No, trivial
invasive.
trauma patient comes with isolated Turner palsy. What you will advise him, or what you will look for?
In isolated Turner palsy, we can look for any fracture of the orbital wall.
Not fractures, those things will have all other associated symptoms. A trivial trauma presenting with Turner palsy can be a simple isolated Turner palsy or somewhere in the trunk. Without this one, that's a rare thing. So what you should rule out is whether it is what type of total Turner palsy, if it is there or it is there or not.
Yes, sir.
You should rule out aneurysm, ruptured aneurysm. A trauma can lead to ruptured aneurysm and cause Turner palsy. So it may be an emergency.
Yes, sir.
A trivial trauma presenting with Turner palsy. That's about nuclear lesions. Okay, what are the vesicular lesions of Turner palsy? What are the symptoms associated with vesicular lesions?
Vesicular lesions, the causes are vascular causes, aneurysms, and
What are the symptoms associated with vesicular lesions?
Benedict syndromes, Benedict syndrome, Weber syndrome, Nutnagel syndrome, Claude syndrome. In Benedict syndrome, red nucleus is affected and patient will have ipsilateral Turner palsy and contralateral tremor. And in Weber syndrome, this cerebral pyramid is affected, so patient may have contralateral hemiparesis. And in Nothnagel syndrome, the superior cerebellar peduncle is involved, so patient have contralateral ataxia symptom. Then in Claude syndrome, patients will have both the symptoms of Benedict's and Nothnagel syndrome.
Okay, is this pupillary sparing is an always phenomena? In all the cases, do the pupil spares?
Sometimes, if there is any underlying evolving lesion is there, people may involve later, so we have to follow up the patient.
If it is diabetic is the cause. Is that always it spares the pupil?
In diabetic, in vascular cases, sometimes we may get pupillary involvement. It is not exclusive. Sir.
What is the cause for pain in this patient?
Pain. Patient patient may have any neurologic pains.
Ischemia. Ischemic pain.
Yeah, yes, sir.
Okay, how do they present if it is in the lesion in the cavernous sinus?
If the lesion is in the cavernous sinus, there may be any associated other cranial nerve involvements, sir. Like fifth cranial nerve and other sixth cranial nerve may be affected along with it.
How do you differentiate between anterior cavernous lesion and posterior cavernous lesion?
anterior along the anterior side of the cavernous sinus, the oculomotor nerve divides into superior and inferior division. So
No, differentiates between anterior cavernous lesion and posterior cavernous lesion.
I don't know, sir.
Others can also answer, I think. Vaishna?
Yes, madam.
Yeah. How do you differentiate between anterior cavernous and posterior cavernous lesions, sir has asked.
Anterior cavernous lesions normally there'll be involvement of third, fourth, and fifth nerve, whereas in posterior cavernous lesions, mostly the sixth nerve and the V1 and V2 branch of fifth nerves are involved.
No. Only 5.1 and 5.2, ophthalmic and maxillary. In posterior cavernous lesions, maxillary also involved. In anterior cavernous, only ophthalmic division is involved.
Okay, sir.
What are the signs they will present within cavernous sinus lesions? If there is lesion in the cavernous sinus, how do they present?
Aishwarya?
Yes, madam. Cavernous sinus are third, fourth, and sixth nerve will also be
Total
involved. So
ophthalmoplegia,
lateral
right?
rectus will also be total ophthalmoplegia will be
Yeah.
there.
Okay. Then what else will be there?
Mm.
Is there will be proptosis? Do they have proptosis?
In case of CCF,
Yes.
yeah, can have doctor.
Cavernous lesions will have proptosis or not? No, they will have proptosis mild. Can anyone tell what is the cause for proptosis in this? In cavernous sinus lesions? Other PGs also can answer.
Fatima Shakira? You heard, no?
So cavernous system will
Again,
have
all nerves involved. So loss of tone of the muscle. So eyeball will be slightly pushed forward. They will have mild proptosis. Along with the other signs you didn't mention, congestion, all those things, pain. What is the cause for pain in that? Cavernous sinus, pain is a feature. Fifth nerve involvement. Okay, Rohima, what do you want to do for this patient?
Sir, in this patient, since the diabetic control is poor, we'll ask the patient for a diabetic control, and we can refer the patient to a physician for high glycemic control. Then we can.
Okay, one is control of diabetes and a systemic diabetes condition, right?
Then we can refer the patient to a neurologist to rule out any intracranial causes. Then we should follow up the patients.
Do you want to do imaging or not in this patient?
Here in this case, the pupil is not involved, imaging is not required immediately. We can follow up the patient, and if later if the patient is developing pupillary involvement, we can go for imaging like CT angiography and MRI and all.
What you will tell about the patient? Patient will ask for the prognosis.
We can tell the patient that the symptoms will improve over time. It will take time like 3 or 4 months. If it is not improving, then we can go for other.
All patients, you will ask them to wait for, it will take 3 months.
No, sir. We
Usually
can.
improvement will be within most of the cases 2 weeks to 2 months they will improve
Okay, sir.
in diabetic third nerve policies. Okay, if it's not, we'll say in case if it is not improved, how do you manage?
If it is not improved, we can look for if there is any pupillary involvement.
Okay, all investigation you have done, then what you will do?
We can give conservative methods, like we can occlude the eye. Occlusion therapy can be given. Fresnel prisms we can give. Then
So you want to occlude. What do you want to occlude here?
for
What
to
is the
prevent
role of why you want to occlude?
to prevent contractures.
Contracture, you want already ptosis is there. What occlusion you are talking, I didn't get.
Patient does not have diplopia, right?
Yes,
Does he have?
yes, madam. Patient does not have diplopia.
Only partial recovery is there. Then what is the management in the future? I want to know.
If partial recovery is there, patient may present with diplopia, so we can give spectacles. Spectacles.
Spectacles. What for spectacles?
We can give prisms.
Okay. You want to give to avoid diplopia, right? Okay. Anything can you do for to prevent the what is a sequelae can happen in any this concomitant squints?
Long-term concomitant squint may cause contracture of the muscles.
Okay.
So we yes.
Can
So
you
we
tell what is spread of committance? Sequelae of concomitant policy.
this is due to the constant pull of the
You know what is spread of committance or commitization?
patient may develop restrictive element also.
Do you know what is spread of committance?
Fate of committance. No, I don't know, sir.
Sequelae of concomitant squint. When they partially recovered, the concomitant squint may appear in the later stages as a committant squint. Others, what is spread of committant or commitization?
Hafiz?
Can anyone answer?
Dr. Hafiz?
Say partial six nerve palsy is there. After some time, few years, if you see, they will appear like a committant squint.
So under action of
Sequel of
parietic eye,
changes that occurs.
under action of parietic eye, followed by overaction of contralateral synergetic muscle, then overaction of ipsilateral
Then first
antagonist.
one, what happens to the involved muscle?
Involved muscle under action, sir.
Yeah, weakness of the involved muscle.
Yes. Then followed by overaction of the contralateral synergistic muscle.
Correct.
Then overaction of the ipsilateral antagonist muscle.
Okay. Initially overaction, later what happens?
Then inhibitory paresis of contralateral
Contracture.
antagonist.
Inhibitory policy of the antagonist of the yoke muscle. That is the spread of committance or a sequel of concomitant squint. So just because I say concomitant squints, I ask these questions. Maybe you are prepared only for third nerve palsy. Now, what I wanted to know is if it is incomplete recovery, what is the next option other than you give botulism, contracture, all those things phase over, still there is not complete recovery. What is the next option? Any third nerve palsy, maybe this is diabetes, other third nerve palsies, what is the next line of management? Surgical management, no?
Surgical management.
what is a prerequisite for before going for the surgery? When you plan for the surgery in these patients, this may be these cases mostly 99% they will recover, maybe due to some other post-traumatic or some post-aneurysm they may.
Wait for at least 6 months
Okay, why you want to wait for 6 months?
to see if there is any improvement before planning a surgery.
Yeah, one is improvement, other one is they should end up with stable deviation before doing any surgery. That is usually 6 months. So there should be a stable deviation which should be there for 6 months. Then you have to plan for surgery. Okay, I think your scheduled time is over. Soumya,
Yeah.
already 9:05, I think.
Yeah.
Yeah.
I think we had a good discussion. Anything else you people have to ask, you can ask, because this is a very important aspect during your examination. Your examination can go in any ways. It need not be only to your diagnosis. So you should be thorough with almost all parts of whatever you are commenting upon in your paper, like how in this case it went to an NPDR, right?
Yes, ma'am.
So you should be knowing about all those things also before commenting or writing anything in your uh, examination paper during a
Yeah,
practical
somehow
exam.
this is bit confusing. Our findings and this one. No, even she's not mentioning microaneurysm also. Only hemorrhages, maybe CR waiver probably.
Yeah. Why the vision is 618 and not improved? So there is
That is
definitely there
also
should be a cause.
yellow with macular edema probably. I
Yeah.
cannot tell.
And if at all there is a cataract also 58 diabetic, you do not know, so you have to look out for any posterior subcapsular cataract in this case, if it is there or not. That could be another cause where there is no pinhole improvement in this case. So always when you're commenting, look at the vision, why it has not improved, what is the cause for that. That also has to be seen, I
So
think.
in this case, probably instead of you telling the severe NPDR, so you should better you can tell the differential diagnosis unless you have other findings which are suggestive of diabetic retinopathy.
Yes,
Other
sir.
than hemorrhages, you are not commenting anything about other things. Very
Yes.
unlikely. Your other eye fundus, how is the other eye fundus?
Other eye fundus was
Both
also.
eyes similar, no?
Yes,
Okay,
sir.
okay. That goes more in favor of maybe diabetic. Okay, it was a good presentation.
Thank you, sir.
So I think Dr. Rajesh.
Yeah, I am here.
Yes.
Okay, we will wind up the session. I think there was a lively discussion, and sir has gone through well, like an exam. I think, and it might have very good effort on part of Soumya and team. I, on behalf of KSOS, I would like to thank everyone who made this today's program a success, and add my deepest gratitude to Dr. Suresh sir for pouring his valuable insights today's program, and also Dr. Soumya, my classmate. Thank you for sharing this session, and also Rohima. You made a very good presentation. Thank you, Rohima,
Thank
and
you,
all
sir.
the other participants for making this today's discussion a lively. Thank you all. Thank you.
Thank you.
Thank
Thank
you,
you.
sir.
Thank you, sir.
Good night.
Thank you.
Good night,
Thank you, sir.
everyone.
Thank you. Good night.